Good afternoon, my friends. Happy Wednesday. The doctor is in the house. Welcome back to another episode of To Your Health with Dr. G on such a great day. I tell you what, today's show, as always, is going to be fierce. It's made for you to spread the love, spread the information. I cannot wait to talk today about estrogen. Now, a few months ago, if you guys remember, I did a show about testosterone, and the response was overwhelming, and people said, Dr. G, you got to do a show for the ladies about estrogen. And so here we are. Today's topic, that estrogen show, myths, facts, and other realities. Again, my name is Dr. Mark Gomez. I'm a board-certified internal medicine physician. I practice at Edward Hospital in Bolingbrook in Naperville, Illinois. I tell you what, I'm also a lifestyle medicine advocate, member of the American College of Lifestyle Medicine, and I'm so excited to welcome everybody back today to a great episode. And I tell you what, you guys are in for a treat. I have my great colleague here. You're going to meet her in a second, and I tell you what, we're going to break this down for you. Just like how we did for the fellas last time, we're breaking it down for the ladies. And again, the best thing that you could do today is share this information. Again, we want, as physicians, we want you to have your best opportunity to live life to its fullest. Remember that your health is a foundation for everything that you do in your life. Remember, prioritize what you want to do, why you want to do it, and then come up with the how. And again, your physician's going to be there with you the whole time. So again, I'm so excited to welcome everybody back to another episode of To Your Health with Dr. G. Again, my website, www.drmarkgomez.com. Again, today, we are going to break it down. Estrogen has a real talk about this topic. Before we get into everything, I want to hit you with a quick disclaimer. The content of To Your Health with Dr. G is for informational and entertainment purposes only, and that the content is not intended to be a substitute for professional medical advice, diagnosis, and or treatment. Further details can be found at www.toyourhealthwithdrg.com/disclaimer. So here we are today. I love this topic because again, I get excited about hormones because you have to realize this. Hormones are like everything. Hormones really set the foundation, and hormones are chemical substances. And in essence, they're like a messenger. Hormones are made by one tissue, one part of the body, and they go to another part of the body and they tell it what to do. And I just love that messenger aspect, but hormones are so powerful. And a lot of times we get some things confused. And so we're here today to hopefully help set the record straight. Now remember, we're just talking today. Again, the most important thing that you can do, those of you that are listening, is if you have any questions, talk with your physician. He or she will be more than happy to answer questions. We're going to try to break it down. Got kind of a little of a grab bag kind of thing, mail bag kind of thing, some questions. Of course, we're going to get into my favorite part of the show, as always, myths versus facts, later on and everything. But again, we're going to break it down for you. I just can't wait. So let's do this, as they say. So I want to introduce you guys to my guest today, my panelist. She is phenomenal. She's taking care of my patients. She's a friend and colleague out at Edward Hospital. I want to introduce you guys to my great colleague, Dr. Mietelski. She is a board-certified obstetrician and gynecologist. She's also a fellow in the American College of Obstetrics and Gynecology. She's with Edward Elmhurst Health. Check her out, www.eehealth.org. Dr. Mietelski, welcome to the show.
Thank you so much for having me. It's a pleasure to be here.
I am so excited that this worked out for us. And when I came with this idea and I reached out to you and I was like, okay, Megan, we got to do the show. And you're like, let's do it. And I was like, let's do it. So there it is. We're here now doing this.
Exactly.
Which is great. So I'm so excited about this. Let's do this. Tell us where you went to medical school. I'm all about establishing credentials.
Sure.
Everybody knows that watches the show here with Dr. G. Credentials mean a lot of things, but these are my trusted people. Again, we're all about building trust and delivering truth. Dr. Mietelski, where'd you go to medical school? Where'd you do your residency?
So medical school, I went to Loyola University Medical Center, Stritch School of Medicine, which is in Maywood, Illinois, right down the street.
Yes.
And then for residency, I was at the Medical College of Wisconsin, Affiliated Hospitals, technically. It's a really long name, but it's Milwaukee, basically.
Well, wonderful. And we connected, of course, through Edward Hospital, and then we connected even more when they found like, hey, we're both Loyola Stritch School of Medicine alums. So I just knew there was a reason why we had to connect on this. So this is awesome. So I'm so glad. But thank you for coming out today. What I want to do again, we're going to kind of set the record straight on estrogen. There's so many questions that I get a lot, and I know you get those questions all the time from patients that come in your office. A lot of times for me, I'll try to do the best I can to answer them, and then I'll just punt them over to you, which is great. So that's great to have colleagues and experts that want to share in really providing knowledge and really making sure that people that are out there do well. And so the hormones are just kind of a crazy thing. So give me a few opening remarks from your perspective. What do you think when you hear this topic about estrogen, myths, facts, and other realities? what kind of comes to mind on just kind of the landscape that we're dealing with right now, just to get people the right information?
So in my view, the biggest thing that I think of when people just start to say things like, oh, I think I have hormone problems, or it's my estrogen, or oh gosh, I don't want to take estrogen, that's terrible for you. It's kind of one of realizing that everything in balance is going to either help you or hurt you, but it's got to be right for you. Individualized medicine or approach to whatever your treatment needs to be. You have to kind of decide with your doctor, is it safe for you? What kind of estrogen, if you're going to need it, would you go for? And really just kind of realizing that not everything is all good or all bad, and you just have to decide, is it right for you?
Well, I totally agree. You have to make sure it's the right decision. And I think as physicians, we want to make everything personalized.
Mm-hmm.
We learn a lot about generalizing and kind of approaches based on how people present to our offices. But then you're really trying to say, all right, I got to make sure I can customize to this person's needs and be realistic at the same time. I can't like when I do testosterone, I can't like make my 60-year-old guy feel like he's 20 again,
right.
Or my 80-year-old guy, certainly not my 80-year-old guy to feel like he's 20, but you certainly want to have some realistic expectations with the patients, correct?
That's very, very true.
Wonderful.
Because if you're 60, you're not going to feel like you're 20.
Okay.
But could you feel like you're 40? Maybe.
Absolutely.
Maybe.
I think that's legitimate. If you put your mind to it, you can do it. So let's talk about this concept. We're talking about these hormones, and I want to just kind of lay a little more foundation for people out there. I referenced at the beginning that hormones are really, they're chemical messengers and send the signal and tell the body how to respond to it. And really, I think about the predominant female hormone, estrogen. Of course, men and women have estrogen. Fellas, you got some estrogen in you. Ladies, you have some testosterone in you. But really, I think about this, the thing about these sex hormones, besides them being so powerful, and I think one of the things I try to tell my patients at the beginning is that hormones are released in these kind of like these bursts, these pulsatile manners, and they really are. And so people sometimes will say, well, Dr. G, let's do hormone testing. I'm like, sometimes it's hard to just kind of do because you got these bursts, and sometimes those bursts can last for hours, maybe a few minutes. It could be different during the daytime, different at nighttime, and it's just like it can't be generalized, and sometimes it's so hard to predict where somebody's going. So let me ask you this: so say somebody comes into your office and says, Dr. Mietelski, oh my gosh, I read this magazine, and I think I have hormonal imbalance. I think I'm off. How do you kind of just counsel that person? Because there may be people out there that are watching us right now that kind of say, hey, that might be me, or whatever.
Yeah. So it's, when someone does say something like hormonal imbalance, like you said, there's a lot of different hormones in our body. That's really how everything communicates to each other. So things like estrogen, testosterone, there are other, hormones that are definitely at play. And so I always ask them, when you say you think your hormones are off, tell me what your symptoms are, because that really helps me kind of focus in on, does this sound like this is potentially, a female problem in terms of ovaries or the brain or pituitary gland, but it can be other things too. Thyroid is a very, very common gland that, there's multiple hormones there, and some of the symptoms can kind of cross over because, like you said, these hormones control like everything in our bodies.
It's so true. I always kind of use an analogy. I kind of tell people, I go, your hormonal system, it's like a spider web. It's like there's so many crisscross pathways and everything. You're trying to really make sense, and you're right. A lot of things have so much overlap, and certainly it's when you talk to your doctor after he or she gets your symptoms, and then kind of thinks of a plan. Then we can kind of hopefully pinpoint where a dysfunction may be, and certainly hopefully a treatment plan.
Definitely.
Wonderful. So let me ask you this question. We're talking estrogen. Love this topic. Why don't we just go kind of estrogen 101?
Mm-hmm.
What does estrogen do in a general standpoint? Why do women need estrogen? What's its purpose?
Yeah, so going way back to the beginning, when you're an embryo and you're developing inside, the uterus, basically you are responding to different chemical signals all the time from your mom through the placenta, and the placenta itself does make some hormones. And then as you're developing, you have to decide, are you going to be male or female? And some of that is coming from the genes, obviously, okay. but the hormones are important too, because it influences the development of your different organs and your phenotypic features. So what do you look like? Breasts, hair, where is your hair, etc. And so, for women, estrogen's super critical in terms of determining reproductive function. That's going to be number one in terms of thinking about what does estrogen do in the body. I think all women know, okay, it has something to do with my ovaries, and
Nice.
that it's important in ovulation, and it's also important in making sure that your uterus is receptive for a pregnancy. And then when you get down to it, when you talk about what happens when you don't have your estrogen, we know that estrogen is important for bones, for bone health, and for cardiovascular health. So there are definitely intricacies of estrogen that extend far beyond just reproduction.
That is also, I love how you said that there's intricacies of estrogen that extend far beyond reproduction. And I think we have to kind of take that into the totality of it all and just kind of not have the blinders on. And certainly some of these magazines that are out there, because people read things, we're here to hopefully try to clear the air. It can be misleading and say, oh my gosh, this is the reason, it's my estrogen that's the reason why I'm having all these symptoms, or why I'm having this stubborn fat loss, which may be some truth to some of that, but we have to continue to say it may not just be one single thing. Although I feel like as physicians, a lot of times we're kind of taught that can you figure out somebody's issues with a one singular diagnosis? The kind of like keep it simple approach. But a lot of times it's much more complex than that, correct?
Definitely,
Yeah.
definitely. It would be nice to be able to just say, oh, it's exactly this. But if it was that simple, you wouldn't need to go to a doctor, It would be very straightforward.
Yeah.
But it's very complex.
Oh my gosh, so complex. And I always think about when the hormones come into play, there's so many other factors that come into play that have any kind of thing to do. I mean, your environment, without a doubt. I mean, we sense things. Our conscious brain is out there sensing and surveying things at all times. We have the hypothalamus, which is a part of your brain that just gathers all this amazing information, not from only your external stimuli, but also internally what's going on. And then that information has to be moved somewhere. You got to do something with it. You got to process it, and then you can kind of you bring it to your pituitary gland. Your pituitary gland says, "All right, I'm getting all this information from my hypothalamus, and now I need to start talking to these other glands." And your ovaries for women, testicles for guys. We're talking about sex hormones, but we're trying to say like, "All right, now what do you do with this information?" And then you tell something to function. And I think that, first of all, I always think that that's just marvelous how the body just can kind of work that way. And sometimes we forget about the complexities of our own body, even though we do things rather simply. And I go, wow, the body's so freaking awesome. But at the same time, it can be so frustrating when I have all these symptoms.
Yes,
And so that's the kind of the nuance that we go through, I guess, on a day-to-day basis. So let me ask you this question: are there different types of people ask me all the time, and I'm going to ask you this? But are there different types of estrogens out there in the body?
Yes, definitely. And when we say estrogen, and especially when you hear about it on the on TV or in ads or things like that, they know that lay people just don't know all those different forms of estrogens that are out there. And it really is just a term for a group of hormones that are related to each other.
Okay.
So estrogens, in the adult female, let me put it that way because I'm a regular general OBGYN, there are three main estrogens. So the main one is estradiol, and then there's estradiol, and then my other one that I never even talk about.
Yeah.
What is my other one?
The estrone?
Estrone, yeah. See, the problem is we don't really clinically measure anything other than just estradiol.
Okay, gotcha.
So it doesn't really, it's a nice thing to know about from a research perspective, and knowing that, different preparations of estrogens can contain these other forms of estrogen, but in a practical sense, we don't really do anything with that information clinically.
Let me ask you this question. Say somebody's come in and maybe you are looking at them in, piggyback on what you said about estradiol being the predominant hormone that's out there and certainly premenopausal women. But so you don't really go around, I guess what I'm trying to say is are there times when you say, all right, maybe I need to actually check a level? Because I feel like I get asked the question quite a bit, Dr. G, can you check my hormone levels? And by the way, it's always, can you check my hormone levels without any specifics? But when you kind of read through things, it's really, can you check my female hormone levels? And they want to check some of the pituitary stuff, and then of course the ovarian stuff. But do you routinely check estradiol levels when somebody comes up for just a routine exam?
No, not generally. If someone has various concerns or complaints, I usually ask them, what specifically are those complaints? And of course, in the going over all of their medical history and what else is going on in their life, I usually kind of decide, do we think that you are extremely deficient in estrogen? And, like premenopausal women, it's very hard. They do say things like, I want to check my level. And I'm like, are you having periods? And are they regular? And they're like, yes. And I'm like, then it really is not going to do you any good.
Gotcha.
Because it's fluctuating, as you said. And it fluctuates a lot. And especially in perimenopause, it fluctuates a ton. So if you're still having regular periods, there's really no point in checking it, because we know in the perimenopausal age range, so anywhere from 35 kind of plus up to the average age of menopause at 51, you could have a whole bunch of symptoms of lack of estrogen, but still be menstruating and still have estrogen. It's just symptom-based, if anything.
Yeah, that makes sense. So what happens, let's take the audience through what happens when a woman becomes menopausal. What happens to this hormone, this estradiol that we're talking about, this predominant one? Does it teeter off and other things kind of come in play? How do we kind of distinguish on that?
Yeah, so as you are transitioning towards menopause, basically your ovaries are constantly losing eggs. You're born with as many eggs as you'll ever have. And unfortunately for women, we never really make any eggs. They're always dying off. And when we ovulate, we really maybe only ovulate 400 out of 1 million plus eggs that we ever have in our ovaries. So it's kind of sad because you're losing those eggs all the time. But as you approach menopause, essentially what you're losing is those little cells around the eggs that create the estrogen.
Okay,
It's not the egg itself, but the cells that support the eggs. And those cells basically there's not as many of them anymore to make the blood level of estrogen high. So when you're used to a high estrogen level and then suddenly it's low, or you're pulsing really high and then really low, you can have symptoms from that.
Certainly. So let me ask you this question. When I think about people coming in, because people come in, of course, because of symptoms. There's, chief complaints. Why am I here today? Why are you here today? Well, I'm here today because X, Y, and Z. And so if somebody is kind of saying maybe some of those things, maybe it's a menopausal woman, or maybe a woman that's approaching menopause, she's perimenopausal, and she's saying, I'm having some hot flashes, or I'm having some non-specific fatigue, or I'm having some non-specific mood swings, and you kind of think that, okay, it's probably because she's kind of going through this transition. How do you support that generally? How do we support that? I mean, do we always need to run towards medications? Because I feel like we live in a pill society. I mean, it's not like I feel like we live in one. We live in one. Let's clarify that. Right.
That's true.
Yeah, we live in a pill society. But there's a lot of movement towards doing things more naturally and support people through lifestyle. So, but say you have a person that may come in, and this might speak to somebody who's out there, and I certainly, again, see your doctor. How do you kind of approach that person that might be having some symptoms, and maybe the symptoms are too hard to manage on their own, and you want to support them?
Yeah, so when it comes to, like you said, the perimenopausal symptoms, so the hot flashes, night sweats, mood changes, all of the above, there are definitely different treatments out there, but when we talk about trying to do things that a person can do on their own, it's a lot to do with lifestyle. So believe it or not, I mean, if you exercise a lot, even though in the short term you may feel exercise makes your hot flashes worse, it actually, in general, tends to make them better because you increase your vagal tone. So there's a nerve in the body called the vagus nerve, and it controls a lot of the internal organs and how you respond to things. So if you can increase your vagal tone with deep breathing exercises, meditation, yoga, exercise of various kinds, you can learn to sort of tone down your body's response to all of those kind of lack of estrogen flares, or those hot flash moments.
Yeah, it's very interesting how it's so intertwined. Again, hormones can be so intertwined with so many parts of the body, which again, I was saying earlier, that's the awesomeness about hormones. They really work, because they really have an effect on things. And I think about how when somebody's going to, you mentioned about vagal tone, and we think about something in the system called your parasympathetic system, and that's kind of your rest and digest and kind of processing, but we live in this, what we call a lot of what's called sympathetic tone, our sympathetic nervous systems, which are so active, hyperactive, hyper-stimulated, this fight or flight. If a bear comes in the room right now, you and I, Doc, we're going to try to, hopefully there's no bears out there, but you and I are going to try to bust out this window and hopefully try to run to save our lives. But a lot of times we live in that kind of constant, ongoing stress where it doesn't stop. We were talking a little bit before we got live on the show about how do you balance out so many things when you see different women in your practice that are they're working a 12-hour job, raising kids, trying to make sure that their spouse is doing okay and all that kind of stuff, maybe taking care of an elderly parent, and that can be a ton of pressure to be a superwoman. And then you're like, okay, now I got to make sure my hormones are good.
Yeah.
How do you kind of process that as a doc? Because you see those patients all the time.
Yeah. So, I think for women juggling all these different roles and then especially having your own physiology sort of working against you, it can be really frustrating, especially for, I think, the perimenopausal women because they're sort of going through adolescence, but in reverse. So it's even worse because now...
I love that thing. They're going in adolescence, but in reverse. I like that.
And now, but they're responsible for their children or their spouses or, parents, just like you said. So usually we talk about, what are the things that they can control, that they can make changes, try to take a little bit of stress off of them because the stress only makes it worse, just like you said. So sympathetics, parasympathetics, our world is really, really full of a lot of stimuli, and it's overstimulating. People are chronically stressed, and they don't even know how to listen to their bodies anymore. So there's a lot of dealing with stress and, emotions, anxiety, all that kind of stuff. And usually if you can kind of get a little bit of hold on that, they'll do better. And then we talk about, well, maybe you do need some sort of medication or pharmacotherapy just to help you cope better. But realizing that some of these symptoms maybe will never be completely cured. But again, being able to cope with it and live a quality life where it's not bothering you so much that you can't do your life is kind of the goal.
Excellent. I want to piggyback off your question right there, off your response. And we're talking about this superwoman, this woman who's busy doing a million things and trying to quote unquote balance hormones at the same time. A question that we get asked a lot all the time is like people will come in and say, Doc, I've just got no drive, I got no libido, my sex drive is down, my husband's mad at me now, I'm doing a million things. How do you approach that person? Because they will say, is it my hormones? Or like, I know I'm overly stressed, but I don't want to tell my husband this. How do you kind of approach that conversation in hormones affecting libido?
Yeah, so that's an interesting one because it's obviously a very, very active area of research into sexual dysfunction and libido, and especially for women because it is more complex than just taking something like Viagra for a lot of men. Men are lucky because their physiology is a little bit more simple.
Oh, yes, thank you. I appreciate that.
So for women, though, when we talk about sexuality in general, a lot of it actually is from the brain. Women, their number one sex organ is the brain. So you do have to think about emotions. How is your relationship with your partner? Are there other things going on that you're worried about or stressed about or preoccupied with? Because if there are, it's very hard for a woman to be able to relax and listen to her body and have a sexual response. So, we always have to kind of bring that into the forefront and make sure that those things are okay before really, again, most of the time there's not really anything medical, at least not that we can detect. So we work on a lot of psychosocial sort of issues first, but we do want to make sure that she's well. So a lot of times we'll address things like, well, let's just make sure you're not anemic. Let's make sure your thyroid is good. Let's make sure your kidney, liver function's good. Just the basics, essentially.
Is there a role to test an estradiol level in that person, or do you kind of say, let's look at the other things because you know the situation that it's probably just you're just overstressed and there's a lot going on. But some people may say, well, guys, can you just check my estradiol level? Maybe they're 45, and I would probably say, is it worth it or not? I don't know the question. Sometimes I rack my brain over that, and I do the same kind of approach as you. Is like, let's just make sure we're not anemic. Let's do a few things. I usually get them over to my behavioral health person that I have in my office. But is there a role in that kind of situation to do an estradiol level?
Not really. And unfortunately, again, with estrogen being such a complex player in terms of, behavior in the brain and nervous system function, it doesn't really seem to correlate exactly with sexuality. So even if you gave a woman a ton of estrogen and she was taking it every single day, odds are she probably wouldn't feel any more likely to want to have sex.
Hey, but at least we're setting the record straight here. There's no doubt about that. But it's true. I think you have to look at I love how you said, women's number one sex organ is the brain. Guys, it's another organ, but it can be your brain too. But I'm glad that we're having this conversation, because this is kind of real talk that I think people need to have, and certainly, hopefully, you have this kind of talk with your doctor out there to really help set the record straight. I want to ask this question to Dr. Mietelski. We're going to change topics a little bit. A lot of times, we think about maybe a lack of or an imbalance. We're talking about imbalance of estrogen, maybe low or high. We're talking a little bit, maybe some low stuff. But are there cases of estrogen excess? People may read about this also in magazines and say, well, maybe you have too much, or maybe I need to augment somebody more, make them feel better, just give them maybe a supraphysiologic dose of estrogen and see if that helps out. Do you see signs of excess in people?
Well, again, estrogen excess isn't really necessarily a medical term. So, when you go to medical school and when you go to residency and you're reading about all these hormones, I think, certain terms are very, very broad, and they're not specific enough really for us. So when you say like estrogen excess, I think in the way that people have been referring to it, they basically mean that they are not necessarily ovulating very well. And instead of kind of releasing that egg when your estradiol level hits a certain level, they're not really doing that. And so that estradiol hangs around a lot more than it should. And could they actually have more estrogen just because things are not ever really resolving themselves in the ovary? Maybe. I mean, we don't really check an estradiol level on people like that. Again, it's an interesting, maybe a research question, really. But when you have, irregular periods or other symptoms where we're kind of worrying, maybe we're not ovulating correctly, that kind of, I think, is where people are referring to the estrogen excess, that they have, basically predominance of the symptoms of the first half of the menstrual cycle.
Gotcha. Now, one of the questions I get is really like, how do you know if, they might say, Dr. G, I want to know if my estrogen levels are too low or too high, and I always have to kind of pause for a moment and pull that back and say, again, what are our goals? What are we doing? We can test you ad nauseum, but it may not do anything to change things if certain parameters are not foundational. And so I always kind of scratch my head on that one and say, well, let's just take a step back. What's going on? And maybe we can just balance things out. But I think, again, we also live I said it earlier, we live in a pill society. People want to be tested all the time, and maybe unnecessarily. And as a physician, sometimes it's a little bit more challenging. I'm seeing a little more personally, obviously, where you kind of say, we shouldn't be doing this, but you do it anyways. Sometimes, and then the information goes back and it tells you nothing different, and you kind of say, why did I do this test in the first place? Let me ask you this question. Speaking of hormonal testing, I want to get your take on this one. There are these kits that are out there now. People are doing saliva testing, or they're doing other kind of testing that's out there for women on estrogen levels and hormone levels. Is that worthwhile? Is it all kind of maybe more smoke and mirrors on things?
Yeah, generally we don't feel that the salivary testing is very reliable. And again, that's probably related to the fluctuations that we talked about. So, when you think about what's in saliva, it's whatever your salivary glands are excreting. But, again, if you want to get the closest to whatever the level is that maybe your ovaries are seeing, or, some other organ in your body are seeing, the bloodstream probably is more accurate. But, like you said, pulsatility is a problem, and timing. So a lot of women, if we're going to measure an estradiol level, many times we'll measure it on day 3 of their cycle. And day 3 is just kind of a little bit more of a standardized time in a cycle, where if we're worried about infertility or problems with being able to generate estradiol, that might be a good time to check it. But at the same time, unless it's infertility workup, we really don't check it.
Yeah, I don't see much of a use in doing that kind of testing. I don't get asked that question often, but I do get asked that question from time to time. And one of the things I tell people, I go, first of all, if you were to do a commercial kit, because these are all commercial, the hospitals don't do salivary testing or things like that. But I say, this is commercial. I don't know what the cost is. I may not know how to interpret this because I'm not familiar with this test. Not to say that I can't learn anything, but then what's the clinical utility? And I always try to say, we always try to practice the standard of care. And yes, I'm all about for innovation because you got to be innovative. I think us as younger physicians, we're going to see so many awesome things that happen. And with it's going to be like science fiction. I think it's pretty cool. Medicine is like science fiction now because the things that we're doing now weren't done 10, 15, 20 years ago. But in 20 years from now, they're going to be kind of thinking like, you guys approached maybe female hormones like that? I don't know, but I think you have to have flexibility as we develop. But that's always a tough situation. But I usually try to talk people away from doing something like that. But again, if you're out there at home listening to me and Dr. Mietelski talk right now, you got to make a decision with your doctor. We're just trying to provide some information, but I want you to make sure that you're talking with your doctor on what to go. But again, standard of care is really how we approach things, without a doubt. So let me switch topics a little bit. Let's talk a little bit about, again, the awesomeness of hormones. You mentioned earlier about some of the other benefits that estrogen has throughout the body. You mentioned bones. Let's talk about that. We know certainly that as women get into menopause and those estradiol levels fall and they have a little bit of rise of, I think it's estrone E1 as they talk about it, maybe the predominantly circulating estrogen. But the bottom line is that estrogen normally, when you're premenopausal, has a very bone protective effect. It allows for, it minimizes bone resorption or breaking down the bone and allows for more bone building. So then when women become menopausal, that turns the kind of flips the script a little bit. So how do you approach like women in your practice that are worried about, okay, I'm menopausal and now I think my bones are going to go down. Should I maybe be on hormones? Or how do you kind of approach that?
Yeah, so deciding whether or not to go on to, hormone replacement therapy, which is kind of what we call essentially replacing some of that estrogen that a menopausal woman has lost, it's really personal decision because so many factors go into it. So we obviously, when we talk about that, and even for bone benefits and everything, estrogen's not considered first line, believe it or not, for bones. We do know that physiologically it protects your bones. But when you talk about hormone replacement therapy for menopausal women, you're kind of going a little bit against nature. So you always have to kind of think, well, there's probably consequences to this. And so while it can be good for your bones, and in limited cases, I think you could take a little bit of estrogen therapy to kind of stave off bone loss, but that's really not its primary recommendation. We're really only focusing on using estrogen and progestin, at least for hormone replacement therapy, that is, for the symptoms of being hypoestrogenic from menopause. And again, the bones, we know they're actually more effective medicines.
Oh, absolutely, yeah. There's a class of medicines out there, if you guys are listening, called bisphosphonates, and that's pretty much the first line standard that will allow to prevent the resorption of bone, the breakdown, and allow for more time to do more building of the bones. And that's really a standard of care. So I always try to say, no, you don't need hormones for your bones. There's other medicines that are out there. Let's get a DEXA scan first and foremost and see where you're at. And then let's talk about other lifestyle things to support these, because as we were talking about earlier, lifestyle plays a big role in things. So let me ask you this question. There's so many women out there that go, when they transition to menopause, they have just an inordinate amount of symptoms. And then there's some women that are out there that maybe have won the genetic lottery and literally go through it with grace and no symptoms at all. Why are there differences? Do you ever get asked that question like, oh, my neighbor, she went through this and she was just smiling the whole time during this transition. Mine is miserable.
Yeah, and I think that probably does come down to a little bit of lifestyle and a little bit of genetics, like you said, because the nature versus nurture question, it's never ever going to be answered, because I think the answer is both, And so unfortunately, yes, some people are a little bit luckier when it comes to those genes. But also, like we talked about before, exercising well, eating well, maintaining a normal BMI, those are things that we do know seem to be protective against menopausal symptoms, or at least severity of them. So again, you could still suffer even if you have the best lifestyle, and again, that may be genetics, but that's where it comes in individualization, where we talk about maybe, you are doing everything that you can, but maybe you need a little bit of help.
Excellent. Let me ask you this question. I get this asked all the time. Is estrogen, when it has, when we're going through maybe fluctuations in estrogen, as it relates to maybe mental health, Is estrogen the predominant reason why why women may go through mood swings at all during those cycles, perimenopausal or menopausal? Or do we know are there other things that are not just estrogen fluctuations, maybe, or hormone fluctuations that are driving those kind of mental health challenges?
Yeah, that's a tough one. I definitely think there's hormonal impact or influence on mood, and I wish that I knew even more about neurology and psychology psychiatry, because of the medicines and everything. We know that the neurotransmitters, essentially in some people, for some reason, are just not quite where they're supposed to be. And the problem is, if you look at estrogen, you think to yourself, okay, well, for the most part, normal females all kind of have estrogen. We all fluctuate every cycle when we're having our cycles. And then they all kind of go through the same sort of challenges as you go through losing your estrogen perimenopausally and then menopausally. But then not everybody has the emotional issues. So you have to kind of wonder, there's probably other factors at play. Again, chronic stress, that's definitely a risk factor for causing depression and anxiety and other sort of mood issues. So again, I wish I could say that estrogen was the answer, but I don't think it is.
Yeah, I agree. I think it's much more complex than that one. But it's interesting, as I was doing some research, and some people say, well, if they're going through maybe some mood swings, maybe you give them a little estrogen, and all of a sudden maybe you perk right up. But it sounds like it's maybe too good to be true, maybe too easy. It's maybe a lot more complex than that.
Yeah, actually, it's interesting because estrogen, it's like too much, and you're probably going to be a weepy, emotional mess. But too little, again, you're going to be a weepy, emotional mess. It really is about balance, and again, unfortunately, other factors at play.
Excellent. Let's talk. I love that. It's all about the sweet spot. There's no doubt. I think that's what we're all trying to get when it comes to balancing out hormones and everything, and what do we find the best way to move forward. Let me ask you this question. You mentioned earlier about cardiac protection with estrogen. Women's heart health, huge thing. I tell all my women, if you're between the age of 45 and maybe about 70, go get a heart scan if you haven't been scanned before. 5-minute test, that's my big plug to that one. I did a show on it earlier this year on women's heart health. And so we've got to do that. But we got to talk about heart disease and women, estrogen having a protective effect, certainly in the premenopausal. Say a woman becomes menopausal. We know that there are some challenges that are out there because of estrogen, the lack of estrogen, now having a little more of a risk on those arterial walls. Mm-hmm. How do you kind of approach women from an OBGYN standpoint? You might probably approach women that are menopausal from a cardiac risk, just like how I probably would as an internist. And are you checking lipids? Also, when women come in there for their annual exam with you, are you doing those kind of cardiac measures?
Well, it kind of depends. So normally I will ask, obviously when we gather history, we're always asking, do you have any other things going on? Are there, strong family histories of heart disease? Do you yourself have a history of any cardiac issues or, anything along those lines? And of course, normally I'll ask if someone has had any recent lab work, because a lot of times people are getting it done through just in testing for insurances or through their job, things like that. And I do encourage women to have a primary care doctor. And, OBGYN is really hard because some people want you to be their primary doctor, and they don't realize that as an OBGYN, our training is actually quite limited in the actual primary care field. So when we talk about our prevention stuff, we really are focusing on things like, breast cancer detection. We're really big on colonoscopies. We always make sure people get their colonoscopies. And, cervical cancer prevention and screening, and, HPV vaccination. And we do a lot of STD testing and some counseling about, obviously bone health, like we talked about, because that's kind of an issue that we can have some sort of impact on these younger women that we're seeing. However, for us, I always kind of tell people, I can run some basic labs on you, but really, we don't do a whole lot with EKGs and chest x-rays and things like that in a screening sense. So it's really more appropriate to have a general physician, whether they're internal medicine or family medicine, both are good and they both have their place. So again, it's kind of one of those things where we can start it, But a lot of times if there is something complex or you're going to need medicines for your cholesterol, many OBGYNs really don't want to deal with that. And it's not that we don't care, but we just don't have the training for it.
Right. Well, thank you for clarifying that. And you guys heard it from Dr. Mietelski. Come see me. Come see my colleagues. No, but thank you. No, it's true, and it's very. But it's good about, like, I love about our relationship and everything. You've taken care of some of my patients and everything. But it's like, I know that I can trust you to do what you got to do, but then you trust me back to do what I got to do, and it works out really, really well. So I'm so super excited about that. We got to talk about this related to estrogen, and then maybe we'll get into some myths versus facts. We got to talk about soy. And the whole soy issue. Soy kind of gets a bad rap, and I'll kind of give you guys the soy conundrum that are out there. Soy contains phytoestrogens, and soy, let me take a step back. Soy is very much a nutrient-dense food that's irrefutable. The protein content, the mineral density is amazing. It can be a great substitute for meat. But sometimes when you talk about soy and female hormones, especially estrogen, may get a bad rap. So Harvard actually did something through their public health department and their nutritionists that looked at this kind of question that's out there. Do you advise women to do soy? Do you advise them not to do soy? And what's the scenario? And the research, the conclusion was that, first of all, there's not enough studies. Second of all, the studies vary widely. And third of all, you have to still look at it in the totality of it all. And so how do you kind of approach that in women that might say, Dr. Mietelski, maybe I got some hormonal imbalance, my estrogen, can I eat soy? Do you have a response to that?
Yeah, so I usually kind of ask them more about what do they normally eat, because if someone was kind of thinking of adding soy in, but they already eat a pretty normal standard diet and they are getting dairy and meat, and if they're not necessarily eating organically, and they do eat processed foods, I get a little bit worried because there are, and I can't even think of the word of it, but, endocrine disruptors.
Oh, yeah.
So a BPA and, all these different things that people talk about being in the environment or being in the plastics that we're exposed to and everything. So believe it or not, a lot of women are actually exposed to a lot of estrogenic compounds that they just don't even realize that they are. So I wouldn't necessarily add it in if they aren't already, like, maybe a vegetarian and soy is one of their major protein sources.
Yeah.
So I wouldn't necessarily add it in, or if you're going to add it in, maybe in very small amounts, just to make sure that we're not overdoing it.
Yeah.
Because like we said, balance is key.
Balance.
You really don't want too much and you really don't want too little.
I know one of the things I tell my patients, I go, all right, if you're premenopausal and say, again, we're talking about the peak, this high levels of estradiol, maybe you are going to get a little bit of an anti-estrogenic effect from the soy, and maybe you might have some symptoms. On the flip side, I kind of say, hey, you're menopausal, and then you're having those your estradiol levels really low, maybe you should get a pro-benefit, a pro-estrogenic effect. It's just kind of me, and as I think of things, I go, well, we want to look at the total picture. And so I sometimes when I get cornered with a question like that, I'm like you, I take a step back. What is the totality of what we're dealing with? What is your diet normally like? And then how can we continue to go from there? So I'm like you on that one.
Yeah, and I think it probably would be hard to really hurt yourself by eating a lot of soy unless you're very extreme about it.
Yeah,
but at the same time, again, I'm not going to tell anyone to just go out and convert everything into soy, I think that's that whole trying it in moderation. And, if you feel like it does benefit you, then I think it's a reasonable thing to do because it's in soybeans. It
Absolutely.
is a product of nature.
Yeah.
And, a lot of plant-based foods we know seem to generally be good for us.
Absolutely, yeah. And you guys have heard me talk about this all the time with Dr. G. Following a predominantly whole food plant-based diet will set a foundation for just success without a doubt. So let's get into something that I do every week called Myths versus Facts. I love doing Myths versus Facts. You guys know out there who are joining us and who have been back and repeat listeners to the program, I love doing that every week. It's really about setting the record straight. There's a lot of misinformation out there, and so we want you out there to have the right information at the right time so you can make the best decisions. And again, talk to your doctor and ask questions. I'm all about asking questions, and I don't mind if my patients ask me questions. It does not bother me. I want you to have the tools needed for success. So here's where we go. Myths versus facts. That Estrogen Show. What I'm going to say is I'm going to say a statement, and Dr. Mietelski is going to say myth or fact and tell us why. We'll kind of do like maybe a little rapid fire.
Sure.
I might participate in this, by the way.
Okay.
I'm going to give myself the easy ones.
Okay.
Because of my show, I'm going to give the loud balls. That's how it is. That's how I do.
Home court advantage.
I was telling this to my wife earlier. I go, why do I always take the easy ones? She's like, well, that's just how you are. And I like it. So anyway, so here we go. Myth versus facts, that Estrogen Show. Here we go. Dr. Mietelski. I like this one. Estrogen imbalance is undertreated and underdiagnosed. Myth or fact?
So, as an OBGYN, again, this is a little bit of a hard one for me because I'm not really, again, sure exactly when a patient says estrogen imbalance, what do they mean exactly? So, do they mean they think that, again, they have too much, too little, that kind of stuff. So, when I say estrogen, so when I read that statement, undertreated and underdiagnosed, I would say, no, technically.
Yeah,
because again, I would say there are definitely phases in a woman's life where either high or low estrogen, or just, as we said, kind of fluctuating estrogen levels are all considered to a degree normal. It's when things like a woman who should be ovulating on a monthly basis isn't, that's when I would start to be like, okay, there's something wrong here. And again, maybe it's estrogen, maybe it's not. But for the most part, again, I wouldn't really call it that specifically.
All right, got it. Here we go. I'm going to do one. Here we go. Myth versus facts. This is for me. I love it. You have to live with hot flashes even if they make you miserable. I'll say that is a myth. You don't have to live with them, but I want you to work with your clinician. Again, we talked about the balance of everything. Hormones respond to everything I mentioned earlier about part of your brain collects all these signals. Your body has to respond to that. Your body has to respond to sensors, chemicals, these messengers, but it's more of a bigger picture. It can't just be one pinpoint thing. You gotta look at the totality. So I will say you don't have to live with them. Reality is that a lot of people do, but there's usually things that people can do from a lifestyle standpoint, hopefully to balance things out. Here we go, Dr. Mietelski. Here we go. Myth or fact?
Okay.
Low estrogen is a normal part of aging. Myth or fact?
So, I would say it probably is a fact.
Okay.
Honestly,
please explain.
Because just coming from a purely biological standpoint, when you look at someone without any medical intervention at all, again, the normal reproductive cycle for a woman in terms of her life is going to go from being ovulatory to essentially moving through the perimenopause and then menopause. So I would say, yes, it is normal for that estrogen to fall with age. But again, aging is one of those things where even that process itself, there are varying degrees of symptoms or, comorbidities like osteoporosis, things like that we talk about, that not everybody has that just because they're older. So, again, there's some bit of it where maybe it isn't quite normal, but again, that's a tough one.
Excellent. Here we go. I'll do this one. If your doctor diagnoses you with obesity, metabolic syndrome, or diabetes, then the root cause is estrogen imbalance. That is a myth. It is not estrogen as a cause of your diabetes, without a doubt. It's not a cause of your metabolic syndrome, not a cause of your obesity. There are other factors at play. We want to make sure that we're addressing everything. Again, I think about my patients that come in, I want to look at them from a totality. It's not just one thing. Diabetes is preventable. Type 2 diabetes is preventable probably 80-90% of the time through lifestyle. Obesity as well too, working on lifestyle, and metabolic syndrome, which is people that are at higher risk for heart disease or stroke or diabetes, lifestyle. So think again about lifestyle. Here we go, Dr. Mietelski. Low estrogen can be linked to mood swings, fatigue, low energy, and a lack of drive to get up and do things. Myth or fact?
I would say fact.
Okay,
and
please
again,
explain.
that's part of the whole, again, I think it's individual in terms of could your estrogen fluctuations or having too little estrogen, could that be part of your symptomatology? It could be. And again, it really depends on what else is going on, like we said, because, again, many of these symptoms are actually crossovers from other hormonal systems or other disorders. So unfortunately, again, like we got back to brain chemistry, anxiety, depression, if you give those people estrogen, is that going to cure them? A lot of times it won't. So again, there's always sort of that whole, is that the only factor, and what else is at play?
All right, I'm going to give you another one. Here we go, right back at you. I thought I was going to do a little swap there, but that's all right. I like it. Here you go, Dr. Mietelski. Every adult female should know their estrogen levels. Myth or fact?
Oh, I would definitely say myth on this one.
Okay,
I was going to say false.
False.
False or myth.
Please explain.
Well, again, estrogen levels, like we talked about, as long as a person is not symptomatic, meaning, if it's a young reproductive age woman who is having regular menstrual cycles and not really having any other real symptoms that we'd be worried about, like we said, they fluctuate a lot. So, what is a normal estradiol level? Well, the answer is it depends on your age and it depends on where you are in your cycle, unfortunately. And so, if you said to someone, oh, I had my cholesterol and it was 200, what was your estradiol level? Most people would be like, what? Because we just don't do that.
What's estradiol? I know what cholesterol is.
It's just not as helpful as
A1C
some of those other blood level measurements.
Excellent. I'll take this next one. Here we go. We didn't talk about it too much, but I'll say it real quick. Hormone replacement therapy, HRT, increases your risk of heart disease. That is a fact, and I'll say this. Hormone replacement therapy, when it was originally studied with a large study, over 27,000 postmenopausal women, called the Women's Health, it was the Women's Health Initiative, yes, that was published in 2002, basically combined estrogen plus progestin. The risk of that combined thing to treat symptoms in these postmenopausal women increased the risk not only of heart disease, but also of breast cancer. It made the breast tissue more dense, so hard to pick up on mammograms, or at least diagnosed later on in the disease course. Heart disease, blood clots, and stroke. So now we're not having enough time to talk about this, but there's a whole nother argument for single agent therapy, estrogens in women that have had their hysterectomies.
Yes, and then, just to piggyback on that, the Women's Health Initiative study was kind of a problematic study. It caused a lot of panic in people, and I think a lot of people didn't really take it into context, and many people don't read the actual study for themselves and kind of see what exactly was done to those people or what they did and how they measured outcomes and everything. So, when it comes to the cardiovascular disease, again, as a premenopausal woman, your estrogen is cardioprotective.
Very protective, yeah.
Definitely cardioprotective. And then again, that gets into that whole, well, how much is appropriate for what age are you? Because as you get to the menopause and your periods have stopped, that first couple of years when you really still had pretty estrogenized, I guess you could say, tissues and your blood vessels, they're still pretty amenable to being exposed to estrogen. But at the same time, if you are 10 years out from menopause, should you go start estrogen? Definitely not. Because unfortunately, the study shows that essentially, if you're using the estrogen pretty much just for a few years after that menopausal transition, it actually seems to be beneficial.
Excellent.
But when you're further out, actually the risks seem to outweigh the benefits.
This is more reason to talk to your doctor, without a doubt. So there you go, myth versus facts, everybody. We got about 5 minutes left. This has just been an awesome discussion. I kind of said, oh my gosh, we only got 5 minutes left, but I didn't know that. But this has been an awesome discussion talking about estrogen. So what I want to do is I want to bring it on home. Kind of like when patients come to our office, I mentioned a little bit earlier about acute complaints, when they might be coming in for whatever kind of hormone dysfunction there is. At the end of the day, we call it the assessment and plan, of course. And that is when you, as clinicians, as the physicians, we give somebody their diagnosis, we give them a treatment plan, and of course, most importantly, we give them a follow-up. So, bring it on home, Dr. Mietelski, give us a couple take-home points today. People have been listening to us, they're going to share this show, which is going to be awesome. But what should people out there, especially women that are listening to us, know about estrogen? What are some take-home points from today?
Yeah, so I think one of the big things is to be cognizant that there's going to be good things about estrogen and bad things. And like anything in life, nothing's really 100%. So you have to come to an agreement. And again, I think talking to your doctor is really the only way to go in terms of, are you a candidate for anything along the lines of estrogen, or is there something that needs to be done about your estrogen level? And, again, is that a safe thing for you to do? What's reasonable? And, come to something that can benefit your quality of life.
Excellent. And my final thoughts are this. Really, I want people out there to take from the show is, again, the opportunity that's out there. The engagement is needed, without a doubt. I tell it to my patients all the time. But again, if I can get to somebody and say, what's important to you with your health? What are you trying to do with your life in more of a broader perspective? I think we can kind of get to some balance where we're talking about things. Hormones are powerful substances, as I said earlier. They can have a big effect on the body, but there's so many of them. And it's hard to just kind of say it's one hormone versus a whole bunch of other hormones. We have to look at it in the totality. So people out there that are listening to us today, I want you to just kind of really write down questions. There's nothing wrong with writing down questions. And then talk to your doctor. And then have a discussion with him or her about practical solutions for what's bothering you. Without that kind of engagement from your end, we cannot continue to move forward with opportunity and, more importantly, action. So this has been an awesome show. I want to thank my guest, Dr. Megan Mietelski. Let me read her credentials again because they run deep, as I said in the beginning. Dr. Megan Mietelski, board-certified obstetrician and gynecologist, Edward Elmer's Health. Check her out, www.eehealth.org. Hey, you've been listening and watching live on Facebook and intellectualradio.com. This episode is written by Mark D. Gomez, MD, and Tiffany E.R. Gomez. Producer is Tiffany E.R. Gomez. Music is by the wonderful Mr. Havis. Copyright 2019 by MDG Wellness LLC. All rights reserved. Stay tuned for my show next week. Motivation tips for a healthier you. That's right, motivation tips for a healthier you. Don't miss it. It's going to be awesome. Again, my name is Dr. G. Check me out on my website, www.drbargomez.com. I'll catch you guys later. Peace out.